Thank you very much, Mr. Chairman, Dr. Baculeva, Dr. Torina. Again, thank you for the privilege of coming to this excellent scientific meeting. I'm going to talk about arterial grafts for Cabbage in 2014. I do have conflicts of interest here. My main one is I act as an advisor to a company called VGS, Vascular Graft Solutions, and I'm going to talk about their external stent for vein grafts. I showed this slide this morning showing the current state of play with reference to Cabbage, that almost 80% of patients with 3-vessel disease and 2/3 with left main still have class 1 indication for coronary artery bypass grafting. So Cabbage is the best therapy for most patients with multi-vessel and left main disease, but it has 2 limitations. The damaging effects of bypass caused by microemboli, flow abnormalities, systemic inflammatory reaction syndrome. This leads to biochemical dysfunction in all organs, and it leads to overt morbidity in 15% of patients, particularly affecting brain, kidney, lung. And bypass mortality and morbidity are strongly age-related. And the solutions to these are off-pump surgery, particularly with a no-touch aortic technique, and as we've heard from Professor Carell, miniaturized extracorporeal circulation. The second problem is vein graft failure. We know that there's a variable rate of failure, somewhere 20 to 40% at 1 year. We know that at 10 years, 3/4 of vein grafts are either blocked or severely diseased, and this results in late mortality, recurrent angina, the need for reintervention. There is some evidence these results may be improved by aspirin and statins, but over the longer term, this is not yet conclusive. And the solution to this problem is total arterial grafting. Now, if we look at this very important study by Fitzgibbon, published almost 2 decades ago, Graph A shows the actual rate of vein graft occlusion at 15 years, and you can see that it's 50%. But if you look at line B, which shows vein grafts which are still patent but diseased, you can see that by 15 years, almost 80% of vein grafts are badly diseased. So if you look at the 15-year comparison of Saphenous vein graft patency, it's around 30% in the best studies, but it still does not compare to the 90% you would expect for the internal mammary artery. And that's because vein grafts undergo 2 distinct phases of remodeling. There's an early shear-induced phase. This leads to dilatation of the vein, and there is a later wall tension-induced phase, which leads to thickening and stiffening of the vein, a process we call intimal hyperplasia. So the story of the arterial grafts really started with the Cleveland Clinic's publication of the benefits of an internal mammary artery. This paper was now published almost 3 decades ago, and they showed that 10 years after Cabbage, an internal mammary artery to the LAD reduced the risk of death, myocardial infarction, angina, and the need for redo surgery. And they attributed this to a patency rate of the IMA of over 95% at 10 years, in comparison to 25 to 50% for vein grafts. And this benefit of a single mammary artery has now been shown to persist into the 2nd and indeed the 3rd decade of follow-up. And I think it's a fair comment that if it was not for the internal mammary artery, there would probably be no coronary bypass grafting today. And why is the internal mammary artery different from saphenous vein and indeed the radial artery? It's both on morphological and physiological grounds. The internal mammary artery has a thin, smooth muscle media and a tight internal elastic lamina. But probably most importantly is the fact that the mammary artery produces far more nitric oxide in both basal and stimulated states than either a radial artery or saphenous vein. And the benefit of an internal mammary artery to the LAD was shown in this paper by Lusher, almost now 30 years ago, showing that a mammary artery on the LAD produces far more nitric oxide, which not only protects the patency of the internal mammary artery, but it reduces the development of new disease in the left anterior descending coronary artery. And this has been published now in 5 different studies demonstrating this effect. The other thing I said this morning was putting a drug-eluting stent into the proximal LAD impairs re-endothelialization. It creates a prothrombotic environment, and it impairs distal endothelial function. Now, we know about the patency of a single internal mammary artery, but we also know about the patency of two internal mammary arteries when placed to the best left-sided coronary vessels. And we can see in these 8 studies, looking at angiographic patency of the mammary artery, that for both the left and the right, from 7 days up to 10 years after operation, the patency rates of both mammary arteries are over 90%. Does 2 patent mammary arteries translate into survival benefit? Well, back in 2001, we published this meta-analysis comparing almost 4,500 patients with bilateral IMA grafts, 11,000 with single internal mammary arteries. We did this propensity-matched analysis from 7 databases where the patients were matched for age, gender, LV function, and diabetes, because these 4 factors by themselves give a good indication of likely longevity, even independent of knowledge of the coronary anatomy. And what we found was the hazard ratio for death was 0.8, and that translates into a number needed to treat of 13 to 16 patients to prevent 1 death. But the harsh facts, as I mentioned this morning, are that fewer than 10% of patients in Europe and fewer than 5% in the United States actually receive bilateral IMA grafts. And in an update to this meta-analysis, this is a paper published in Annals of Cardiothoracic Surgery last year. We now look to almost, if you can see at the bottom of the graph, 20,000 patients with bilateral IMA grafts and 60,000 single internal mammary grafts matched for normal preoperative risk factors. And again, we found this strong survival advantage with a hazard ratio of 0.78 for 2 mammary arteries. Now, if you look at this paper from Tatoulis and colleagues, with the co-author Brian Buxton, they looked at the patency of the right internal mammary artery out to 20 years of follow-up. And what they showed was that for the left and the right internal mammary artery, at 10 years, the patencies were identical when placed to the LAD at 95%. When you placed both mammary arteries to the circumflex system, the patency rates were still 90% at 10 years. And when they followed the patients angiographically out to 20 years with the right internal mammary artery, its patency remained over 90%. And there now have been several propensity-matched studies following patients with 2 mammaries out to 20 and 30 years of follow-up. This paper by Kurlansky looked at 2,500 matched pairs and showed a strong survival advantage for the bilateral mammaries, both at 15 years and at 25 years. Another paper from Grau, published in the European Journal of Cardiothoracic Surgery, looked at almost 2,000 matched patients and again showed a survival advantage with BEMA grafts out at 15 years. And this is another paper by Kurlansky's group. They looked at 30-year follow-up in patients with diabetes receiving bilateral internal mammary arteries and again showed this survival benefit. The question then becomes, when there is so much evidence of benefit of 2 mammary arteries, why do we actually use so few in clinical practice? And we tried to answer this in this paper in Heart in 2002, when we wrote to all the consultant cardiac surgeons in the United Kingdom and asked them about their practice of using 2 mammary arteries. 92% said there was probable or definite benefit. Over half of the surgeons said that they thought as many as up to half of their patients would benefit. And 2/3 of surgeons said that if they were receiving coronary bypass grafting, they would want 2 internal mammary arteries. So the question was, why were they not doing it in practice? And only 20% said they did not think there was any proof of benefit, but almost half the surgeons felt that with 2 mammary arteries, mortality, morbidity may be higher, the procedure may take too long, and there is a learning curve to using 2 internal mammary arteries. And of course that's true, there's a learning curve to any proprioceptive skill, whether it's a single internal mammary artery or playing tennis. So to try and push this forward, we conducted this trial. I showed this slide this morning, the ART trial, where we randomized 3,000 patients to single or bilateral IMA grafts. The primary outcome will be 10-year survival, but the point was that the 1-year incidence of stroke, MI, repeat revascularization, and actual mortality were all around 2%. And as I also said, the 5-year outcomes will be reported later this year. But again, only few patients received these grafts. And what did we learn from this trial? Well, we learned that 82% of patients in the ART trial had 3 or 4 bypass grafts. Using a second internal mammary artery added 23 minutes to what was almost a 4-hour procedure. It added an extra hour and a half of ventilation to a mean ventilation time of around 16 hours. It increased duration of ITU stay by 3 hours and hospital stay by 0.5 days, with no other difference in any outcome. I've shown you the outcome at 30 days for mortality, CVA, MI, revascularization, but the one thing we did see was an increase in wound reconstruction from 0.6% in single to 1.9% in the bilateral IMA group. I've shown you the 1-year outcomes, and if we look at the increased incidence of wound reconstruction, that translates into a number needed to harm of almost 80 patients. So for every 80 patients you do bilateral IMA grafts, you will have 1 extra wound reconstruction. However, if you remove from that cohort the obese diabetic patients, then there is almost no difference in wound reconstruction. And the reason for this might be, this is a paper by Bidwani published in Circulation in 2006, showing you the effects of how you harvest an internal mammary artery. The left mammary artery has been harvested in a skeletonized technique, and you can see persistent perfusion to the sternum, whereas the patient's right mammary artery was harvested in a pedicle technique, and you can see that this results in significant decrease in sternal perfusion. There is one meta-analysis looking at the incidence of sternal wound infection in diabetic patients, comparing skeletonized and pedicle techniques. And what this report is that if you skeletonize both mammaries, there is no difference in wound reconstruction between the use of a single or bilateral IMA harvest. But if you harvest pedicled in diabetic patients, they then saw a significant increase in sternal wounds. My only caution to this paper is that we have used bilateral skeletonized mammary arteries in obese diabetics, and we still have noticed an increase in the need for sternal wound reconstruction. So we would not necessarily completely support these observations. If I talk briefly about the radial artery, I and my colleagues published an extensive review of this, published in Annals of Thoracic Surgery last November. And I'm not going to go through it all today, there's simply not time. But the one aspect I want to talk about is the patency of the radial artery in comparison to saphenous vein. And in this randomized trial by Goldman, what you can see is that at 1 year, there is no difference in the angiographic patency of the radial and saphenous vein, 11% failure in both. They caution that you should only use the radial artery if there is at least a 70% stenosis in the native coronary. And they also reported that there was poorer saphenous vein graft patency with endoscopic harvest and with off-pump surgery. And they did not find any benefit of calcium channel blockers in radial arteries. Now, if you look at meta-analysis comparing patency of radial artery and saphenous vein, we can again see that at 1 year there is absolutely no difference in outcome, 14.6% failure for both. However, there is now equally very good evidence that if you follow radial arteries out beyond 1 year and out to 5 years, radial arteries do have consistently better patency than vein grafts beyond 1 year, and that almost simply reflects the fact there is a constant attrition of vein grafts year by year. But it appears that if your radial artery is patent at 1 year, it's going to remain patent on a long-term basis. And there is one paper now by Trento's group in Cedars-Sinai showing that the use of a radial artery in propensity matched patients actually led to improved survival. If we talk about another reason for using bilateral IMA grafts, it's to reduce the incidence of stroke. If we look at conventional Cabbage with bypass, there are 4 obligate maneuvers. 3 of them involve aortic manipulation, and these all increase the risk of stroke, particularly in elderly patients. If we use an IMA and vein graft, we can reduce 3 of these risks by doing the patient off pump, but we still have the risk of stroke from aortic manipulation associated with the top end. And if you use composite arteries based on the 2 mammary arteries and composite arterial grafts, you can effectively dramatically reduce the risk of stroke. And this has been shown in this meta-analysis of neurological complications after off-pump surgery without aortic manipulation. And here you see the relative risk of stroke becomes 0.46. But what is important about this is you do not completely eliminate the risk of stroke even with an off-pump, no-touch aortic technique. And we're beginning to better understand stroke because, for example, around 50% of strokes occur 2 or 3 days after surgery, not associated with the immediate surgical procedure. And the question is, why is that happening? Is it because these patients are flipping in and out of atrial fibrillation? Is it because where you have cannulated the aorta on the inside wall there may be thrombus? It's not entirely clear, but the point is that there is still a risk of stroke with Cabbage even when done as a no-touch aortic technique. I just want to briefly say a few things about off-pump surgery, because for many years off-pump surgery has been reported to give worse outcomes than conventional on-pump surgery, and that's not the case. This is the 1-year outcome of the coronary trial. This randomized 4,750 patients, but unlike most of the other trials of off-pump surgery, you had to be experienced to participate in this trial. The surgeon had to have done a minimum of 100 off-pump surgery cases. And if you look at the mean number of grafts in this trial, it was 3 versus 3.2. Now that was statistically different or reached statistical significance, but this is probably clinically not an important difference. But if we look at the outcomes at 30 days, no difference in death, MI, stroke, or new dialysis. There was a very small increase in repeat revascularization, but a reduction in respiratory failure and renal injury with off-pump surgery. And if you look at the outcomes at 1 year, there was no statistical significant difference in any of the endpoints. So this firmly puts to bed the notion that off-pump surgery does not give you as good results as on-pump surgery. If we look at another study, this was a German study, the so-called German off-pump Cabbage study in the elderly. This looked at 2,600 patients, and crucially, these patients were all aged over 75 years. This was a definite higher risk population. But again, there was no difference in 30-day outcomes and no significant difference in 1-year outcomes in either of the techniques. However, if we look at patients who are at the highest risk and where off-pump surgery has been selectively used, the biggest paper on this is by Kuss, published in JTCVS in 2010, looking at 38 propensity match studies of 123,000 patients. And they reported with off-pump surgery a significant reduction in mortality, stroke, renal failure, prolonged ventilation, the use of balloon pumps and inotropic support, the need for reoperation for bleeding, and the need for blood transfusion products. And they concluded off-pump surgery does reduce all-cause mortality and morbidity. And the probable difference that we're seeing between what the randomized trials are showing and what we've seen from large propensity match registries is this paper by John Puskis, in which he entitled it "Off-Pump Surgery Disproportionately Benefits High-Risk Patients." And what you can see, if you look at the observed mortality and predicted mortality in patients done on-pump and off-pump, if you're done on-pump, your observed mortality increases directly with your predicted mortality by the STS score. In contrast, if you're done off-pump, by the time your risk gets above 5%, there's a relative plateauing effect with off-pump surgery. And these authors concluded the survival benefit of off-pump surgery appears when the predicted mortality is greater than 2.5%, and the survival benefit of off-pump surgery increases as predicted mortality increases. So in the final few minutes, I'd like to say something about this new external stent for vein grafts. As I've said already, my conflict of interest here is I act as an advisor for the company. But this is a cobalt chromium alloy. This means it has two mechanical properties: radial elasticity, which makes the stent both kink and crush resistant, and it has axial plasticity, which means you can stretch it from a starting length of 3 to 6 centimeters to as long as 10 to 22 centimeters. It maintains its in-situ configuration without any necessity of fixation. What are the effects of this stent? It reduces the diameter of the vein graft by around 10%. It reduces lumen irregularities and flow discrepancies. It reduces wall tension, and it reduces the size mismatch between the vein and the native coronary artery. And essentially, it prevents vein dilatation post-implantation. It takes 1 minute to implant the stent, and there is no other change necessary for the technique. And this was the first patient we did, so we've done a randomized trial of 30 patients, where all patients received a mammary artery, and then they received 2 vein grafts, one to the right, one to the circumflex system, and after completion of the distal anastomosis, the patient was randomized so that one of the vein grafts would receive a stent and the other would act as a control. And this is the typical appearance. This was the first patient we did of a stented vein graft at 12 months. You can see this perfect lumen regularity. If you then look and do computational flow dynamics and actually look at the shear stresses and the regularity of the flow, where you see bluish areas, this suggests turbulent flow. Where you see green, yellows and reds, this means very luminal and regular flow, and it means you have far better shear stress in these veins. And remember, shear stress releases nitric oxide, so it helps protect veins. When we measured intimal hyperplasia by OCT and IVUS in these patients, we found almost a 20% reduction in the degree of intimal hyperplasia at 1 year. And this has been the first demonstration of any mechanical device to reduce intimal hyperplasia in the clinical setting. So to summarize this talk on arterial grafts, we can say there is strong angiographic evidence of over 95% patency of both IMAs at 20 years. The ART trial showed that the routine use of bilateral IMA grafts is safe and feasible in most patients. The one thing use of 2 mammary arteries did in obese diabetic patients was it increased the risk of sternal wound problems and led to an overall increase in the need for reconstruction by 1.3%, or a number needed to harm of 80 patients. But you can reduce this with a skeletonization technique. There are meta-analyses and 3 large propensity match registries showing the benefit of bilateral IMA grafts extending over a decade and indeed out to 25 years of follow-up. There is good evidence now that the radial artery provides better patency than the saphenous vein graft after a year. And composite arterial grafts with a no-touch aortic technique reduce the risk of stroke. For most patients undergoing Cabbage, the use of bilateral IMA grafts is more important than whether surgery is performed on or off pump. And the question now is, considering that 80% of all grafts put on the heart today are still vein grafts, might there be a role for external stenting of vein grafts? On that point, I'm going to conclude my talk. I would like to thank the organisers again for the privilege of being here and for your wonderful hospitality, and you, the audience, for your attention. Thank you. Oh, and sorry, if I may show one thing. We run a class, a European master class, twice a year on Oxford, solely on arterial revascularization, all the tips and techniques you need. And if anyone's interested, the next one will be November 2014. Thank you.
When is November?
This year.
No, I understand, but November is 30 days.
Here's the date. Go back a slide.
Yeah. How do I? Yeah. What days? It's
First and second.
No,
that was first. No, it's
this is
all.
13.
It's going to be the 16th and 17th of November. But well spotted. Thank you.
Thank you.
So this is your next conflict of interest.
Yes, I suppose so, yes.
Comments and questions? In your own practice, being a superb coronary surgeon, what is the percentage of patients where you get along with 2 internal mammary arteries and nothing else?
So 80% of our patients will get 2 mammary arteries, and of those, of the proportion who only get 2 mammary arteries and nothing else, it'd be about 50%.
50.
Because we will often do composite, so we will join the right and the left mammary, and that will usually give you 3 good distal ends. If the right is occluded or very heavily stenosed, we'll then use a radial artery from the LAD to the PDA as a coronary conduit. And the other time this technique is of particular value is the 80-year-old patient with a calcified left main, who the cardiologists do not want to touch, because to do 2 mammary arteries off pump is a superb operation. It very dramatically reduces the risk of stroke in that population.
A very short question. The use of radial artery, especially in older patients and the patient with a renal disease, you can have some unpleasant surprises when you prepare the artery. Are there any special tricks how to identify the patient that there is no point in taking down radial artery?
So what we will do is make a small incision in the middle of the arm and examine the caliber of it, and then if it looks good, we'll take it. But paradoxically, even if the radial artery has some calcium, it actually prevents it going into spasm. So we would still use a radial artery even if it's got calcification.
Lorenzo?
David, thank you for your presentation, that it's always charming.
Thank you.
I have a little different point of view, and you know very well because I send you my paper, but you show us clearly that it's important using your device that we increase the velocity of the flow, increasing the shearing stress,
Yes.
and reduce dP on dt.
Yes.
But you can achieve the same goal with sequential veins, where the conditions are almost very similar to that. And yesterday I showed the data, we performed a study in our own patients with a follow-up of 15 years, comparing sequential venous and mammary on left anterior ascending with total arterial. And we found no differences. And this is one point. The other point is if you optimize your extracorporeal circulation, according with the presentation that we have seen before, the rate of stroke decreases dramatically. And we studied the stroke in our own group. In the last 3,000 patients consecutive, we have 5 stroke. So it's true what you show us, but it can face also from another point of view. Your comment.
Yeah. So to answer them in reverse order, so I'll do the second one first. In terms of stroke, if you look at Syntax trial, which is a big trial, big randomized trial, the stroke rate, certainly in the left main group, was 4%. If you look through the literature, there is consistent reports, particularly in the elderly population, of a significant increase in the risk of stroke with any aortic manipulation. So anything that you can do to reduce the aortic manipulation, especially in elderly patients, is very useful.
This is partially true, because we don't know nothing about hemodilution during that intervention. And if you change your hemodilution from 15 hematocrit to 27 hematocrit, your stroke is deeply go down.
Yeah, but there is very good transesophageal echo studies that have been showing that the volume of disease in the ascending aorta directly correlates with the risk of stroke. I mean, there is a great deal of evidence showing that, hard objective evidence, and it therefore becomes very intuitive or logical to understand if you manipulate these diseased aortas, you're going to significantly increase the risk of stroke. And I think the evidence in that is overwhelming.
Excuse me, a short question. How long does it take you to perform OPCAP arterial cardiovascularization procedure?
I'm sorry, how long?
How long does it take to perform OPCAP procedure total?
So if I do 3 grafts myself off pump.
Free grafts.
Yeah, so for most of my...
I think the question is from the beginning, right?
How much time, yeah?
Yeah, how long is from the very beginning?
If I do myself?
Yeah, yourself.
About 2 hours.
2 hours.
If I do it with my trainee, closer to 3 hours. But I can, I've been harvesting 2 mammary arteries for more than 15 years, and it takes me about 20 minutes per mammary. So
for both?
No, each. 20 minutes to do skeletonized.
Both?
No, sorry, 20 minutes per mammary. Per mammary.
So 40 minutes?
40 minutes, yes.
Okay, thanks.
David, I think there is no doubt that the skeletonized internal mammary artery is the conduit of choice.
Yeah.
Why are so few people using skeletonization? Even now you can hear the big papers and AATS which use pedicled mammary artery.
Yeah. It's very difficult to understand this, and I mean, it's equally difficult to understand why so few patients get two mammary arteries. But when you're used to skeletonizing a mammary artery, it has a number of advantages. It is longer, it is wider, so it makes doing composite grafting easier. And also by not denuding the chest wall, by leaving tissue on the chest wall, it's been shown very strongly to reduce the risk of sternal wound problems. So why so few people use it, I don't understand. But it's one of these things, once you do it, you would never go back to using it any other way.